Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Enclose II Proximal Anastomosis device. Good morning, everyone. My name is Gianluca Torregrossa, and I'm a cardiothoracic surgeon who works at Lankenau Heart Institute in Philadelphia, United States. One of my big passion is coronary artery bypass grafting, the surgery meant to treat patients with the most common cause of death in men and women above the age of 55, coronary artery disease. In the last 20 years, we have tested patients with coronary artery disease to receive either a percutaneous coronary intervention, PCI, or coronary artery bypass grafting. And the consistent answer of all of these more than 18 randomized trials has been the same. Coronary artery bypass grafting is the best treatment for a long and durable effect and treatment of coronary artery disease. Unfortunately, coronary artery bypass grafting comes with a big burden. Generally, a very big incision performed via a central access requiring the open of the front bone of the heart, the sternum. And more important, the fact that we have to stop the heart, we have to sew the bypass together and restart the heart and wean the patients from cardiopulmonary bypass machine. More than 20 years ago, in the mid-90s, a new phenomenon called off-pump bypass grafting was started to be pursued and refined from a technical point of view. This technique was meant to offer the same advantage of coronary artery bypass grafting, but without stopping the heart, without connecting the patients to the cardiopulmonary bypass machine, but rather sewing the bypass while the heart was still beating. Unfortunately, the technique has been tested as well in different trials and has never proven to be superior from a statistical point of view to the more common bypass performed with a cardiopulmonary bypass machine. At the current time, off-pump represent less than 10% of the total volume of bypass surgery performed in the United States. One of the major reasons of the lack of supportive evidence of off-pump coronary artery bypass grafting comes from the management of the proximal anastomosis. The time in which we connect veins or radial artery to the ascending aorta to complete the bypass grafting is the time in which we play with the most important risk of CABG surgery, the risk of stroke. Stroke is when, during a time of the surgery, somehow the perfusion of the brain is not optimal, and the patient has an injury or has a problem due to that event. Stroke is managed because or was not shown to be inferior in off-pump bypass grafting because all of the early experience of off-pump has always been performed with what we call a side clamp of the aorta. So the major vessel, the aorta, inside the chest was clamped partially with a device, creating a potential risk for embolic source from that aorta towards the brain. And that's what has limited or nullified the real benefit of off-pump in protecting patients from stroke. Stroke is a very complex disease, is a spectrum of disease. And despite the fact that the major disabling stroke that impair the patients and their own progression to go back to normal life are, thanks God, a rare complication that happen in less than 1% of the total bypass grafting. But it is true that more and more we recognize that patients that get connected to a cardiopulmonary bypass machine, that they have their ascending aorta too manipulated, they go into a proper risk of have neurocognitive decadiment. So grandpa and grandma or the 55 years old that goes into coronary artery bypass graft surgery has a successful surgery, but is not as functional as it was before after the surgery. And that is exactly the time in which we need to scale up, to move forward new technology that helps surgeon to offer patients a better treatment for completing proximal anastomosis. Treatments that avoid stroke, avoid minimal manipulation of the aorta, making sure that the patient goes back as a functional individual to the lifestyle that was performing before that defined surgery. And Enclose II by Peters Surgical is one of the most important devices available in the market to make sure that these proximal anastomosis are performed in a complete bloodless field without a major manipulation of the aorta. I'm here in this beautiful setting to talk about this device, and I share my passion for it. I use it in my daily practice, in my daily activity, and I found it extremely reliable in more than 700 proximal anastomosis performed in the last 3 years. This device is inserted in the aorta via a small opening that is done with a needle, and once deployed, offer a complete, very tight space to perform the proximal anastomosis with minimal manipulation of the aorta. The device has a de-airing system that makes sure that no bubbles or no debridement get caught in the insertion or the removal of the device itself, and allows surgeon not only to perform safely proximal anastomosis, but also to teach how to perform safely off-pump bypass to the next generation of residents. I believe that there is, at the current time, a huge need to investigate better proximal anastomosis in bypass grafting and the role of devices like Enclose II to improve outcomes in our patients. A lot of times, the way in which we test these outcomes is very subject and very complex. Define the neurodecognitive degradiment of patients after surgery is a very complex statistical task. But it's our responsibility as surgeon to be exposed to this device, to be familiar with the device, and understand the unique feature that allow you to avoid to side clamp the ascending aorta with the risk of debridement of endothelium and other material from the aorta towards the brain. This device has a long history of production, has been extremely safe in clinical practice, and can change the way in which you offer proximal anastomosis both in on-pump and off-pump. In off-pump, it's clear the advantage of a device like this, but even in scenario like off-pump bypass grafting, this device can become an excellent tool. In fact, in cases of long cross-clamp time, there is the possibility for the surgeon to remove the cross-clamp time, let the heart restart and beat, and complete the proximal anastomosis using this device while the heart is still beating and is still reperfusing. This is my preference strategy in case I have to perform a complex surgery, a mitral valve CABG surgery in a patient with low ejection fraction. In this case, I do not want to have a cross-clamp time. I don't want to arrest that heart for too long. I want to minimize the time of ischemia on the heart. So I perform the distal of the coronary and the valve surgery in a single cross-clamp time. And then I release the cross-clamp, I insert the Enclose II device, and I perform the proximal anastomosis. Again, I believe that personal education as a cardiothoracic surgeon with this device, but even as a cardiologist, is extremely important to ensure that our patients in 2024 receive a surgery that is more advanced than what patients were receiving 20 years ago. We are responsible for the outcomes of surgery, and it's our responsibility to get acquainted with the devices and new technologies that allow us to operate in a better way or in a safer way for our patients and their outcomes, not only defined as an outcomes of mortality at 30 days, but the real outcomes of being able to go back to their normal life as they were before the surgery. Thank you so much for this time here with me, and thank you for listening to this focus spot on Enclose II, and I will be happy to take any question. Thank you.
Let's meet at EX 2024 in Lisbon on the booth 230 to discover more about surgery, education, and innovation.